Good morning. This is Dr. Ara Deuk-Machen, CEO and founder of Deuk Spine Institute and the Surgery Center of Vieira, where we're here today. And we're going to be performing a live spinal surgery for the viewers to watch and learn as part of our commitment to education and truth and basically showing the public what exactly happens in spine surgery. The type of spine surgery we're doing this morning is a very special kind of spine surgery. It's endoscopic. Endoscopic surgery is surgery that's done through an endoscope. Endoscopic surgery done through an endoscope means you're doing small incision and you're using a tube to work through, as opposed to doing a big open incision, which is going to cause more scar tissue and collateral damage and risk for the patient, bleeding, infection, etc., tissue trauma. So endoscopic surgeries are less invasive than open surgeries. They're being done in every field of surgery, from general surgery to ENT, orthopedics, neurosurgery. Endoscopic procedures are performed routinely, and in spine surgery, endoscopic procedures are gaining in popularity because of their minimally invasive nature combined with their very good successful outcomes with respect to relief of symptoms and low risk of complications. So this patient here is having a 2-level cervical Deuk laser disc repair. Deuk laser disc repair is the name of the surgery that we're doing. It was developed at Deuk Spine Institute. It's a form of endoscopic spine surgery. We perform this surgery on the cervical spine and the lumbar spine. Cervical spine for neck pain, with or without arm symptoms of pinched nerves or pinched spinal cord. And we do it on the lower back for back pain, with or without leg symptoms. Leg symptoms and arm symptoms include weakness, numbness, pins and needles, or pain going into the arm or leg. So our patient here injured his neck and lower back and thoracic in a motor vehicle accident. And he has injuries to multiple discs and joints in the spine. And earlier, before I start this surgery, Dr. Patel did a RFA, radio frequency ablation. Now we're going to be performing a cervical Deuk laser disc repair. All right. We ready to get started? We're relaxed? Perfect. Yeah, I wouldn't go any lower right now. So, just to orient everyone, this is the chin. The face is here. The patient is intubated. They're completely asleep. They have a tube down their throat, and they're being ventilated and monitored by our anesthesiologist, Dr. Calcarney. And the chest is here, so the right side of the neck is exposed. And this is a right approach, correct? Everybody agrees? All right, so let's go ahead and get started. I need to see where we are on the lateral view shot. So 2, 3, 4, 5, 6, 7. 2, 3, 4, 5, 6, 7. All right, so we're a little lower than I want to be. We're doing 3, 4, 4, 5 today. All right, so I want to get up higher in the spine. And he's totally relaxed, correct? Yeah. Yeah, good, perfect. I don't feel any contraction of the pharyngeals, so shot. 2, 3, 4, 5. So we're at 5. We still need to go a little bit higher. No, it was fine. Shot. All right, so I need an AP view. Now, one of the risks of our surgery is that the patient will not be able to, just a quick AP. All right, thanks. Go back to a lateral. Will not be able to get one of the discs treated, and that's always a possibility. And the reason that's a possibility is everybody's anatomy is slightly different. So, shot, 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 AP, Coker. So I've entered the anterior longitudinal ligament. Shot. There's a quick AP. Perfect. Lateral. I'm happy with the position of the tip of the needle on the AP view. I'm pretty much in the midline where I want to be at 4.5. I would like to change the angle of the needle or the trajectory of the needle, the beveled edge, because it's aiming down. I want to aim up. Shot. Shot. All right. We're going to do a discogram now that we're in good position within the disc. Again, that's 2, 3, 4, 5. You agree, Luis? I agree, sir. 2, 3, 4, 5. Shot. So there it is right there. You see the tear in the back of the disc? That black dye just shot out through the back of the disc into the epidural space. And you can actually see the herniation. That's that lump of black. So what I'm injecting is omnipaque and some indigo carmine dye. The indigo carmine stains degenerated nucleus pulposus basically, and the omnipaque shot. Perfect. So you can see the guide wire has went to the base of the herniation basically, and now I'm going to take the needle out. Shot. I want to make sure as I get this needle out I don't move the guide wire. So for those of you watching, this is November 21st, correct? 2019. I just want to say there's a lot of people, doctors out there that are proclaiming to do laser spine surgery, but they're not really doing laser spine surgery. They're basically just using it as a marketing ploy. So patients and consumers need to be careful where they go for their treatment, because there's only one place in the world really to get anterior cervical endoscopic surgery, and that's right here at Deuk Spine Institute. There's lots of doctors now that are not qualified to do these procedures, that are claiming to do laser procedures, and what they're really doing is they're just putting a laser probe on the skin, and they're basically just doing like laser on the skin, which they're saying penetrates, which is a bunch of nonsense. Laser is light, basically light type energy. It doesn't really penetrate through your skin. It may go and heat up some tissue below the skin, but it's not doing anything unless it's directly in contact with the pathology, which is the herniation. So what you're going to see today is surgery where I directly contact the pathology, where I'm actually going to vaporize away the herniation and any bone spurs that I need to get rid of that are causing nerve compression. Okay? So I've made my incision with a number 11 blade. Nope. And now I'm bringing this dilator down. How's our blood pressure?
95/67.
All right, let's try to keep it
90?
around where it is or lower. So what I'm trying to tell you is that there's a lot of scammers out there in medicine, that they're doctors that are scammers, or business people that are scammers. I hear this all the time. Stories like, for example, I've been doing these endoscopic laser surgeries now for 13 years, going on 14 years. And everyone wants to copy me, but they don't have the training or skills or the equipment to do it. So here's what they'll do. They'll advertise that they do laser surgery. They'll get the patient there, tell them that they're coming in for surgery on the day of surgery. The patient will even show up to the surgery place to get that laser surgery, and then they'll say, oh, your insurance won't cover it. We're going to change it to a different kind of surgery, like an artificial disc or a hybrid. They'll make up some nonsense. And it's basically a bait and switch. That's really what it is. And you don't expect to see that in healthcare with doctors, but they do it. Many doctors are shameless, and honestly, they have no personal integrity. So this is not a doctor bashing session. I don't want to turn it into. But what these surgery broadcasts are they're about the truth. And some people don't want to hear the truth. That's fine. Just turn it off and go away. But these broadcasts, if you want to learn the truth in healthcare and what's really happening, I'll tell you the exact truth. All right? I'm not going to tell you about open heart surgery because I have no idea anything about open heart surgery except it involves the heart. But when you want to talk about spine surgery, laser spine surgery, endoscopic spine surgery, minimally invasive surgery, fusions, artificial discs, anything to do with spine care, I am an expert, and I'll tell you exactly what I know. And I won't tell you something that I don't know. So if I tell you something, it's because I've seen it, I know it's true, it's verified, it's happened over and over again, and it's worth talking about because it affects you, the consumer. Now, I realize that the audience for these surgeries is public and that we don't charge. There's no subscription to watch these surgeries. We broadcast these surgeries live, unedited, from beginning to end. So if you're watching this surgery right now at 9:49 in the morning, you're watching a live broadcast. November 21st, 9:49 Eastern Standard Time. You're watching a live broadcast. Why that's important is because we don't edit any of these. Again, they're live surgeries, live streams. We want the world to see the truth. I'm not trying to hide anything. I have nothing to hide. If we have a complication, you're going to see a complication. All right? Are complications automatic lawsuits against the doctor? No. Absolutely not. Malpractice, if you think, why is this doctor broadcasting his surgery? He's crazy. If he has a complication, he's going to get sued. Yeah, sure, I could get sued. Absolutely. But I truly believe I won't lose a lawsuit. Why? Because I'm not doing anything wrong, below the standard of care. Having a complication in spine surgery is not below the standard of care. It's not malpractice to have a complication. It is malpractice to not recognize the complication and to not treat it properly. That is malpractice. So not diagnosing a complication or not treating a complication properly is malpractice. Sure, I'm exposing myself to some paid doctor to say my work was below the standard of care, and that's a risk I take. But I take that risk because the benefit is to teach the public the truth about spine surgery. So yes, I'm taking personal risk. I'm putting my entire life savings at risk to show you all surgery, because I want the world to know the truth, because nobody else is showing it to you the right way. Nobody else is telling you the truth. So that's one of my goals in life, is to teach the public about spine surgery and how it can be done safely and effectively. All right, AP. So people wonder all the time, why are you broadcasting live surgeries? You must be crazy, showing everyone what you're doing. You know, don't you want to keep this secret? Go ahead. Don't you want to just be able to do it yourself? Really, I don't. I mean, I want everyone in the world that needs spine surgery to be able to benefit from this technology that I have, that I created. That's perfect. We're in the midline. Go back to a lateral. So the only way I'm going to do that is by making the world aware of what we're doing. Okay? So for many things that are developed in life, they're very secretive, right? People that have spent the time and effort and energy and money to develop technology, they don't want to share it with everyone, right? So if you're building a television that's the most advanced TV in the world, you don't want your competitors knowing about it. If you're building a stealth bomber, you don't want your competitor to know how to do it. So you're not going to show them the plans. But for me, I don't really have competitors, and I want all patients with herniated discs to be able to have this surgery and not have to go through a fusion surgery, which is the alternative, or an artificial disc. So the only way that's going to happen is if I share what I do with the rest of the world. And that's why we do these broadcasts. Shot. So we're using X-ray right now. That's what you're seeing. And if you look up at C2, C2 is the bone further up towards 12 o'clock. And I can't really describe it except it looks like it has a pointy part that points up like a finger. So it's the first vertebrae that looks different as you go up. So if that's C2, then we count down. The next one's C3. The next one is C4, and that's right above where I'm operating. And then C5 is below. So I'm doing the C4-5 disc right now. This is a Deuk laser disc repair. Again, the only place you're going to get this surgery in the whole world is at Deuk Spine Institute here near Orlando, Florida. And this surgery replaces fusion. Now, I've done over 1,000 cervical fusions in my career and many artificial disc surgeries, but this is a far better surgery than a fusion surgery. Shot. So I have to advance this dilator without advancing the guide wire. And it appears the guide wire wants to advance, so I'm going to pull it back a little bit. Shot. Are you pulsing? You should always be pulsing, okay? When you can. Shot. So this is definitely a case that you can pulse. All right, so you can see the dilator tip has entered the disc space, and I'm just using my fingers to twist it and gently manually advance it. Shot. So I'm not able to advance it very well at this point, but I'm safely in the disc. So I'm going to bring the mallet in. Shot. Because I can advance it better with the mallet. The mallet is a hammer, and it's just safer. Because I can deliver controlled bursts of energy to the dilator. Shot. And I'm going to bring this dilator right to the base of the herniation. Shot. Okay, so there's the herniation. There's the tip of the dilator. The herniation, you can see an outline of it's black from the dye that we put in earlier that outlined it. Otherwise, you won't be able to see it on an X-ray. So normally you cannot see herniations on X-ray unless they're calcified. This is not a calcified herniation. It's a relatively new herniation. It's soft. So I'm going to go in there and I'm going to remove the herniation. But I guess I should show you what I'm using. So true endoscopic surgery is done through a small tube. This is a small tube. This is the smallest tube in the world to do endoscopic cervical surgery. There's nothing even close to this. Everything else is this much bigger. So this is a tiny tube. It's 4 millimeters wide, one side to the other. So we make generally about a 4 millimeter incision. And I'm going to put this tube and slide it down my dilator. So this is a system of gradually increasing the diameter of the tubes, which I did not develop myself. It was developed by a German company, and all this is FDA approved equipment. So you can see the entire surgery will be done through this tiny little metal straw. But I've got to get this thing down into the herniation, so that's what I'm doing right now. Gently twisting it and advancing it. Shot. Once I get to the disc, I'm at the front of the disc. I can feel it. Shot. I'm banging on the annulus fibrosus. I've got to go through it, and I've got to advance this tube down to where the herniation is. So to do that, I use this impactor and a mallet. Shot. And I can feel it advancing. And you want to check your advancement frequently because you don't want to advance it into the spinal cord. The spinal cord is right at the tip of that dilator. So you see the dilator move just a little bit in. That's not good. So we don't want to move any further in. We've probably got about a couple of more millimeters of room there, but I'm not going to take a chance. Shot. So, shot. We use little bursts of X-ray radiation to get a picture. It's absolutely essential, shot, that we use the X-ray machine during this procedure. It cannot be done without an X-ray. Shot. That's my shot there. Shot. All right. That's better. So again, you want to have the tip at the base of the herniation. Shot. And I want to advance. Went back in. Shot. 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 Perfect. So now I'm up against the herniation. The herniation is the part of the nucleus that went out through the annular tear and I'm at the base of the herniation, the part of the herniation that's closest to the center of the disc. So I've got my tube in. Can you all see that?
Yes.
All right. You can see the cut in the neck right there. We're going from the front of the neck. That's the best way to get to a herniated disc. Okay? Normally, surgeons that do this type of surgery, not the endoscopic, but the anterior cervical approach, you have to take the whole disc out to get to the little piece in the back. But you see, I didn't take the disc out. I went through it. I passed through the normal disc to get to the herniation in the back. And now I'm going to take the herniation in the back out using an endoscope without taking the disc out. So you all see this? Can you show them this, please?
Yes, we can.
Can you see the whole thing?
Yes.
All right, this is the endoscopic rig, we call it. Basically, you have an endoscope, you have a camera, okay? The camera attaches to the back of the endoscope. So this is the camera in my right hand. I'm moving it around. All right, this is a high definition camera, and it attaches to the back of an endoscope, and this endoscope is specifically made for spine surgery, that the type that I'm performing. It was developed by the Koreans, South Koreans. They're the first ones really, and a couple of German surgeons, to do anterior cervical endoscopic surgery. We call this transdiscal because you go through the disc. Trans means across, discal, through the disc. So this is anterior cervical transdiscal surgery. Okay? I wasn't the first one to do anterior cervical transdiscal endoscopic surgery. There was a German surgeon and there was a couple of South Korean surgeons that were. But I learned from the original people years ago overseas. I brought that technology to the United States, and I've been doing this surgery for 13 years, and we've had 0 complications to date. Well, keep the lights on. I want to show our audience a few more things. So stay with me. Are you still on my rig?
We are.
All right, what this tube is, this is irrigation, okay? So irrigation is liquid. It's saline, basically. So I use saline. It runs through the endoscope, and it clears out all the debris from the laser. So otherwise, you'd have all this, like, gunk just sitting there. You wouldn't be able to see what you're doing. So the irrigation is essential to clearing out the gunk and keeping the tissues cool. Otherwise, the laser would heat everything up. It'd superheat it. Now, the laser fiber is right here. It's the blue fiber. It goes into this port. We call that a port. There are 3 ports to the laser, 1, 2, and 3. So the middle port's for the fiber. The side ports are for irrigation. This here is the light source, okay? This is a fiber optic light source. You can disconnect it. Luis is backing up. He doesn't want it shining in his eyes. You all see that? Pretty cool, huh? So this is it, the endoscopic rig. Camera so I can see, light source for illumination, irrigation, laser fiber. All right, this is all going to head down into the disc right now. And now that we're inside the disc, remember we're going through the normal part of the disc and we're leaving the normal part alone. That's the beauty of this surgery. You don't take the whole disc out to get to the little piece in the back that's being bad. Where's my pedal? Is our laser ready? All right, I think we can improve on this image. I think it's too blurry. I'm going to play with the focus. Nope. All right, and then I think it's too bright. Let's turn it down just a little bit. All right, now I'm activating the laser, and you can see things starting to shake around and move. That's the laser energy being delivered to the disc. So there's a big piece right there. Standby laser. I want to grab that piece of herniation out. Now, herniations come out as multiple pieces usually. Rarely do you get one big piece coming out at one time. So it's about, it's just about chipping away. That's what we have to do as surgeons. We got to chip away at it. All right? Even when you're doing an ACDF, you got to chip away at it. Use scrapers. This is way too overexposed. I can't see anything. Way too bright. I don't know what you guys are doing. Get that light down, please, now. No, you're not adjusting anything. you kidding, guys? How about the other one on the other box, Luis? Don't you know how to control this thing? That's the one, guys. Please. Can we get it? Can we get this stuff right? I mean, I do my job right. You guys have to do your job right. That's way too dark. Well, try that. Let's see what happens there. Let's see what happens on the bottom brightness.
Nothing. That's what the problem was. Nothing was working.
Well, it's always the one that you're handling right now. That's the proper one. It's too bright. That's probably okay right there. Right there. All right. All right. My staff feel that I'm too good at these surgeries, so they want to give me challenges. They love to distract me from what I do. Right, guys? You want to make it more entertaining. I get it. I get it. All right. You want the audience to feel some angst. All right. So, long story short, we're in the back of the disc. We're right at the herniation. There's some scar tissue here. There's a piece of herniation that just came out. There's a piece of herniation, the blue stuff. So people say to me, how do you know what's what? Well, so let me remind you, I've done 1,000 of these surgeries, okay? And before I did 1,000, I had done about 800 ACDFs, anterior cervical discectomy and fusion. So those ACDFs that I did, every patient, I probably took out an average of 2.5 herniated discs with a microscope. With a microscope, I could see, but you don't see as well as an endoscope. The microscope is clear. Look at that herniation right there. You see the blue? That's called a reverse herniation. We coined that term here at Deuk Spine, right there. That herniation was sitting out there in the epidural space in the foramen pushing on the nerve root. And I just freed up some scar tissue behind it where the inflammation was going on, and that allowed it to pop back in because it was under pressure on the nerve root. Now it popped back in the disc. I'm going to go take it out. So that's one fragment of the herniation, but that's not the whole herniation. There's many more, I promise you. There's probably at least 5 pieces that size. At least 5. So there it is. I took it out with a grabber, and we're going to send that to the pathologist so they can look at it. We do that for all the disc herniations just to make sure, well, basically to make sure the pathologist gets enough money they can buy their kids Christmas presents. Standby laser. Got another piece. Once you start using the laser to zap away the scar tissue there, these fragments start coming out. So let's show our audience a fragment.
Lights on, please.
Light on. Can you show them here? You
Yes,
see
we
that?
see it.
Can you guys see that? That's a fragment of herniation. And I use this grabber here, this beautiful $1,000 piece of metal, to grab it. Oh, yeah. And I pull it out. All right, thank you, Luis. Here you go. And we're going to just collect all those fragments that are back there pushing on the nerve and the spinal cord. And that's a herniated disc fragment. And you saw how it's blue. It's normally not blue. It's blue because I stained it blue. And the reason I stained it blue is I put that dye in here, all right? And that dye is very special. It stains degenerated disc. When we say degenerated disc, we're not talking about chronic degeneration. This is a degenerated disc from an accident this patient had. And what degenerated means, what it really means, and most doctors don't even know this, it means that the disc material has been worked over by your body's inflammatory system. So if I take a herniation that's fresh, just happens right now, the nucleus pulposus, it won't be degenerated unless the disc itself is degenerated to begin with. But if it's not, it won't be degenerated. It's actually the action of the body trying to heal that herniation that causes the disc to degenerate over time. So the nucleus pulposus degenerates in response to the inflammation. In response to the inflammation that it creates within the annulus fibrosus. There's another herniation right there. I can see it, but it's not coming out yet. But we're going to free it up and it's going to come out. You'll see it in a minute. That's probably the biggest piece I've seen so far. I don't know if it'll come out in one piece or if it's going to come out in multiple pieces, but you can see it. That shouldn't be there. That's sitting right on the nerve root. So we're going to get rid of it one way or the other. It's stuck down right there. It's scarred to the disc. Come on now. Questions from our audience?
We do have a couple.
All
One-
right, I'll take the questions.
One viewer asks, with a transdiscal approach, is there a risk of herniation at the place at the front of the disc where you enter?
Oh, that's a great question. So one of our viewers says, Dr. Deuk, if I followed you correctly, you went through the front of the disc to get to the back of the disc. You're correct. I did. So the answer is yes, there is a risk of herniation in the front of the disc, but it's extremely small. I would say I increased the risk of herniation by 1 in 1,000. And here's why. When I went through the front of the disc, I didn't cut the front of the disc. I literally pushed through the fibers. So go ahead and turn the light on for a second. Can you see my hand?
Yes.
All right. My fingers represent the fibers in the front of the disc. This represents a relatively sharp object. I went to the front and I pushed through, okay? I pushed through, but I didn't cut the fibers. When I come out, the fibers close back. So there's been no cutting of any type. I just have to check my glove to make sure I didn't cut my glove in any way. I don't see any cut, but that's the idea, is we're literally just spreading fibers. So there is no real increased risk of herniation except maybe a tiny bit, because we're not cutting anything in the front of the disc. I'm just spreading the fibers apart, and they're being held apart by the tubular tractor, and then they're coming back together when I leave. So no, I don't think it really significantly increases the risk of anterior herniation. But even if it did, anterior herniations never cause pain laser on, and they never cause nerve compression because there's no nerves in front. And they never cause spinal. There's another herniation right there. See that? A couple of pieces right there. Those are just totally detached. So I don't think it increases the risk for the patient at all. You know? It would be like, to me, the increased risk for a problem from going through the front of the disc would be the same as a normal person going outside in the sun for 5 minutes, developing, skin cancer from 5 minutes of exposure. It's virtually impossible. You have to have a lot more exposure than that. I said normal person. I'm not talking about somebody with a genetic defect. All right, there's part of the herniation down there sitting right on top of the spinal cord and nerve. So it doesn't want to come, so I'm just going to zap it away a little bit at a time. You can see it's kind of golden color because it's starting to calcify. Oh yeah, come on. There it is. Beautiful. You guys see that? Amazing. I tell you, I love doing this surgery. It's so gratifying to get these herniations to come out. And no fusion, guys. This patient would have had a fusion anywhere else they went. This is if you can't do anterior cervical Deuk laser disc repair, you're having a spinal fusion or artificial disc. Those are such traumatic, invasive surgeries. But that's what everyone's being offered these days. One of the reasons we broadcast these surgeries is so people understand they don't have to have a fusion. Now, have I ever had a patient where I wanted to do this Deuk laser disc repair and I couldn't do it? Yes. Some people do end up not being able to have it done. But it's rare. It's probably less than 2% of the patients that can't have the Deuk laser disc repair. That's because they have a completely collapsed disc with giant bone spurs squishing the spinal cord or nerves. Those are not good candidates for the Deuk laser disc repair. And I'm not going to have somebody to do that kind of surgery if it's not going to work. That's unethical, and I don't do things that are unethical. I went into medicine to help people, and so that's what I always do, is I try to help people the best I can. All right. That's looking good. We're not done, though, by any means. There's still more work to do. There's more herniations. Look at all this stuff back here. So this patient had a really bad injury to the neck and their lower back and their thoracic spine from I think from a car accident. And
Krista, can you just shut that suction? Please, yeah, it's not doing it.
is that the suction for here?
No.
Oh, for the bag?
Yeah. No. Only the bag. Yes.
Another piece. I try to usually float these pieces out so I don't have to stop and grab it. I'm kind of going over to the other side. I'm going over to the patient's right side right now. So when you do the anterior cervical endoscopic surgery like I'm doing, you can actually do both sides of the disc. So if they have a bilateral herniation that's affecting both sides, both nerves, you can actually treat both through one incision, one procedure, basically. Whereas with the lumbar spine, in the lower back, I have to pick right or left. There's a piece of herniation too. And I usually go on the lumbar spine on the side that they have their worst leg symptoms.
We have another question.
Yes.
A viewer asks, is the neck laser disc repair more difficult than the lumbar?
Is the cervical Deuk laser disc repair more difficult than the lumbar? The answer is yes, by a 100-fold. I mean, first of all, if I do a lumbar, like the chance of hurting a patient is so small, it's almost, for me, it's almost non-existent, to be honest with you. Cervical, it is nerve-wracking every time because you have to go past the carotid artery jugular vein. You have to go past the esophagus, trachea. You have literally a 2 millimeter wide path, and you have to be in that 2 millimeter wide path. So if someone wanted to learn this procedure, a surgeon, it would be a lot easier to teach them lumbar than cervical. Cervical is so much more complex and risky than lumbar. So to answer your question, yes, cervical is a lot more difficult, more challenging, more risk than lumbar. But that being said, I've been blessed with not a single complication in 13 years, and I've done 1,000 of these laser surgeries. I would say probably 600 lumbar and 400 cervicals. So certainly more lumbar than cervical. And that's just anywhere you go, I think. People generally have more back problems than they do have neck problems. I would say it's probably a 2/3 to 1/3 ratio if I had to guess. And I see a lot of people from all over the world, and I don't think that changes no matter where you live. Whether you live in Canada, United States, or in a foreign country. Injuries to the lumbar spine are more common. Injuries that are symptomatic are more common in the lumbar spine. Maybe it has to do with the fact that the lumbar discs have a lot more pressure on them from all that weight of your body, the upper body going down on it. Whereas the cervical discs, they only have the neck and the head and the shoulders and arms, whereas the lumbar have all the upper extremities, head, neck, plus all the abdominal organs that are weighing onto the spine. And the rib cage, the chest cavity, everything up there gets pushed down onto the lumbar discs. So I think that's why lumbar disc herniations are more symptomatic or more common, is that the discs are larger and they bear more weight, and there's more movement typically in the lower back than there is in the neck. All right, so we're down in the foramen at this point. You can see most of the herniation is gone. There's just a little bit of this filamentous stuff here. But you can see kind of the dura down there at 6 o'clock. Kind of the last fibers of the posterior longitudinal ligament, and then there's dura just underneath them. A lot of times with these type of herniations, they're basically underneath the posterior ligament, meaning that they don't, when I say underneath, I mean on the disc side of the posterior longitudinal ligament. They don't penetrate the posterior longitudinal ligament. They're not up against the dura, is what I'm trying to say. In other words, that's good for the patient. We call it a contained herniation. A lot safer, easier to fix than a herniation that's out in the epidural space up against the dura. So this to me looks like it's a contained herniation, at least so far from what I've seen. MRIs, I can't tell you for sure, but I can tell you in my vast experience of treating herniated discs in the neck and back that at least 75% of them are contained, meaning they don't penetrate the posterior ligament. and get into the epidural space, which is good. It means they're safer and easier to remove. All right, I'm done with the patient's left side. I'm going to switch my scope over to the right side because I'm seeing herniation here as well. And I want to make sure I don't leave anything behind that would cause problems for this patient. There's fibers of the posterior ligament right there. Some of this disc material right here is like collagenized, like right there, which means that it's been worked over by the inflammatory system pretty badly, pretty extensively. So where it's all completely scarred up. Remember, when your body does inflammation on something, it's going to cause scar tissue. And the longer it's doing inflammation, the more scar tissue that's going to form. Actually, most of this is still central, paracentral. But you can see where the herniation was sitting right here. It came all the way up to here. Those are all, that's your posterior longitudinal ligament fibers. The white stuff going across from left to right, those are your PLL fibers. Most surgeons have never, spine surgeons have never even seen this view. But you can see it quite well with the endoscope. It's very safe. That's one nice thing is I'm able to use my anatomical knowledge of the cervical disc and herniation with this surgery because the visibility is just so good. To be honest with you, most spine surgeons never see any of this stuff because they don't use a microscope in the hospital. They don't use loops to see down here. Your loops can't see down here. And most surgeons, like orthopedic surgeons that do cervical disc surgery, they may use loops. That's about it. But a microscope costs $200,000, a good microscope. And so a lot of hospitals don't have them. So the surgeons are operating blind. They can't see any of this. I can see this so well with the endoscope. You can see the anatomy really well. So in many ways, the endoscopic surgery we're doing right now is safer than these open surgeries because our visibility is so much better. And I'm just floating out pieces of herniation. There's kind of the dura right there, posterior ligament and dura blending. And there's a little bone spur, but it's not doing anything. I'm not going to do anything with it. And that's really the extent, the lateral part of the foramen right there. I think we're pretty much done. I'm just going to go look one more time. We're done at this disc. Now 3-4, the next disc is really hard to get to. So I don't even know for sure we're going to be able to get to it. We're going to see. But for me, I'm prepared to get rid of people's pain in their back and neck with surgery when it's appropriate, but I'm not prepared to risk someone's life for them to die from my surgery. I don't believe that's a fair price to pay for anyone. So I don't do crazy stuff. If the surgery is going to happen and it's safe, then I'll do it. But if I can't get to C3-4, I'm not going to risk killing this patient just to do one more disc herniation. That benefit is not great enough to take that risk, right? So if you have a brain tumor, you're dying from a brain tumor, you've got to go get that brain tumor out as a surgeon. If you don't, the patient's going to die. On the other hand, if we don't get that disc herniation out, why is the pedal doing funny things? I'm kind of stepping on the side of it, I think. The pedal's too light, too flimsy. Is there a way? I wonder if we can, like, I don't know. Yeah, but it's just too easy to move around. Huh? Yeah, talk to the rep. For those of you who don't know, we bought a laser, our first laser. They're about $100,000 machine. And it's nice because it gives us lots of flexibility with being able to do the surgeries when we want.
You prefer the old pedal, the old one? The old one is just like a capsule, just like a box.
I know. I feel like I feel like I like it better. Are they going to give us the old one?
I mean, I can check. I can try. At least I can try.
I don't like the two pedals. Yeah, I don't like the two pedals.
No, but the old one is just like it's a box.
All right, Sean, you must have more questions. Give me a second, Dr. Kulkarni. I know there are other questions from our audience, and
Yes.
I'll be happy to answer yours as well. Yes.
We have one viewer who's asking, would you be scared to do this surgery on one of your family members?
Would I be scared to do this surgery on one of my family members? No. Absolutely not. I would not be scared. Because I've already done it on my family members. I've done it on my best friend, my best friend's family member, my family members, you name it, I've done it. Trust me, people come from all over the world to have this surgery, and my family members are no exception. They get disc problems too. And they don't want fusion. They want this surgery. So they travel. Most of my family's in Los Angeles, so they've traveled from LA to come here and have the surgery done. I can't give you names, obviously, but just out of HIPAA violation respect, I don't want to violate the law, but yes, I've definitely done my family members. I've done my best friend. I've done my best friend's daughter's surgery with a laser, and she was only 15 years old. She had a herniated disc that all the surgeons, all the orthopedic surgeons, all the big shot doctors in Los Angeles missed it because it was so small. And they didn't think, they thought it was in her head. They wanted her to see psychiatrists. They saw 3 different orthopedic and neurosurgeons for her back pain. She was 15 years old. Conservative treatment didn't work, so they called me, and I fixed her. Her pain is gone. It's been gone for 10 months now. She's a basketball player, and she's going to be able to go back and play. We got an irrigation issue here. Why is nobody checking the irrigation? There's definitely a problem. Yeah, you got to keep an eye on that irrigation. So yes, I've already operated many times on many family members, best friends, friends' families, little girls, boys. I'm not afraid at all because I know this is the best surgery in the world for them. And I always try not to do surgery if it's possible to fix people without surgery. But some things need to have surgery, and there's nothing else is going to work. So, you know, if you know something needs surgery and then you don't do the surgery, you do shots or therapy, all you're doing is prolonging the inevitable. And for a lot of patients, they have pinched nerves with nerve damage. So you're basically just going to cause the nerves to be damaged longer if you don't do the surgery. There's many studies that have shown early surgery for disc herniations is good rather than waiting too long. What's too long? Well, it depends on the symptoms the patient's having. It depends on their physical exam findings. If they have weakness or spinal cord damage, the surgery needs to be done immediately, without delay, without anything else being done conservatively. If they have pain only and no neurological deficit, then conservative treatment's appropriate. So when I do surgery on people, I know what I'm doing is right, and I don't have any second guessing, and I don't get scared or nervous. I mean, sure, doing the surgery itself is a little nerve-wracking, right? And that's true. And I've done 1,000, and even after 1,000, I still have anxiety, right? But it's normal, you know? Even Usain Bolt has some anxiety when he's standing on the starting line for an Olympic race. Every athlete, every performer has some anxiety. Many of them treat their anxiety with drugs. I don't do drugs. I don't drink alcohol. So naturally, it's normal to have some anxiety and some care, concern, and that's every surgeon that I know that cares about their patients and their outcomes has some degree of anxiety when they're doing treatment for a patient. And surgery is no different, you know. Surgery is very complex. You have a patient's life in your hands. They trust you, their family trusts you, their friends trust you, everyone trusts you, and frankly, you have to make sure they come out of the surgery well. Not just alive and doing well without complication, but also you have to fix the problem they went into surgery for. Yeah, so we're done with this disc at this point. I've gotten all the herniation out. I've gotten the bone spur out that needs to come out. There's very minimal bone spur, by the way. It's tiny. So this is more of an acute type disc herniation, or subacute, I would say, rather than really, really chronic. So we're going to move on to the next disc, or at least we're going to try to. I may need you to give me some inline traction, where you take the head and just pull straight towards you to kind of give me a few extra millimeters of room. Now, Luis, I've got a bag full of water here. It's about to overflow.
And then when you come without AP,
Hold on. Can you bring the fluoro up, please?
watch the monitor, don't touch the monitor.
No, stop. Not up, but like this side up.
Yeah, AP.
This side up. Let's go. Swing it. All right, here comes the liquid. Wait. Where's the laser fiber? All right, good. Leave it. Yeah, it'll do it on its...
Hey, you need to change that canister.
All right, there's a little bit of water here on the drape. Dr. Calcarni, you had a question. And then I'll come back to you, Sean. I don't... Okay, yeah, I'll let you know, but I'll check in a minute. But his pharyngeal constrictors, his strap muscles, I don't feel any response.
You got a crystal?
What's the learning curve? So our anesthesiologist, Dr. Kulkarni, is asking me, what is the learning curve for a surgeon to learn this procedure? I mean, it depends on the surgeon's experience, knowledge, how good they are at surgery, how knowledgeable they are of the anatomy of the neck and the discs. So if it's a resident, in training, I mean, it really depends on their intelligence and their knowledge of anatomy and their ability with their hands. Some surgeons will never be able to do the surgery. Just like some surgeons can't do open heart surgery. They can't sew a valve in, or they can't do a AAA repair. They just, either they don't have the confidence, they don't have the skills, or they don't have the motor abilities, the motor skills. They don't have the three-dimensional understanding. So those surgeons are going to put the patients at too high of a risk. But I'm lucky because I have all the right stuff, So if you have all the right stuff, like me, I think you could learn this surgery with probably 20, 25 cervical, 25 lumbar. It would be safe at that point to do it. So it really is a fellowship. It's not just a weekend course.
Initially, you have to do with the preceptor.
Yeah, you have to do it in a fellowship type situation. You need someone teaching you and observing you, supervising you, just like in residency or fellowship. Okay, let's go back to a lateral, please. Let me see the neck. It is getting a little, I think we're okay. I think we're okay. I may just need you to extend the head slightly with some inline traction with slight extension, but I'll tell you in a minute. Don't do it yet. All right, so at this point, let's get these cables out of the way, please, Luis. Let's get the laser fiber pulled back so we don't break the tip. All right, at this point, we're going to now go from C45 to C34. At least we're going to attempt to. So, and again, I'm going to only do it if I can do it safely. Shot. All right, so first thing I'm going to do is remove the tubular retractor. Okay. And we'll be putting that back in a minute. You can see everyone here, right? The incision. So now I have to remove this shot out of the disc space and dock it in the front of C4 vertebral body on the ALL. Shot. So that's what I'm going to do. This is the hardest part of the whole surgery. I need quiet, please. Shot. All right, so I need an AP view. I got to make sure that I'm not off to the side. I'm kind of taking you through my thoughts as I do this. Somebody who's experienced and knows what they're doing. Shot. Yeah, I think the neck is supple. I don't need any more relaxation. Coker. Get ready for a shot. Then I want a lateral. No. Get ready for a shot. Shot. Lateral. So I moved up north towards C3-4 disc. I'm keeping the tip of this right on the ALL. I am not letting it lift off for 1 second. That's where I'm at. So we're pretty close. might actually be able to do this. Shot. So I got to advance it north about 3 millimeters. Shot. That's perfect. Give me a AP view. I got to make sure I'm in the midline. You don't want to start banging this thing in and you find out you're in the vertebral artery or the carotid artery. Shot. All right, so I'm a little bit off to his left. I'll bring it back just the slightest amount. Shot. Perfect. Lateral. So this is very doable if you know what you're doing. Right? Of course. Perfect. All right, so that's perfect positioning for C3-4. Mallet. Now I have to advance this into the ALL shot. As I'm doing this, I want to make sure I am not getting to the side. Shot. Let me have a AP. That's current. Okay, good. Nice job. I like how you anticipated. See, I'm capable of complimenting people. You're doing a great job too. If I'm not saying anything to you, you're doing a good job. All right, that's perfect. We're right in the midline. So go ahead and go lateral. So basically, if you understand the anatomy of the spine and neck, where we are is we're passing right through the anterior longitudinal ligament of the spine, which connects all the vertebrae through the front and discs. And we're right between what's called the longus colli muscles, right in the middle. And right between the longus colli muscles, there's a little space of about a centimeter where there's just anterior longitudinal ligament and veins. And the veins really are on the vertebral body, not on the disc space. So we're in a really good place. We'll call it the safe zone. We'll call it Deuk-Magen's rectangle. Hey, I like that. Or maybe it's more of a square. We'll coin it. Deuk-Magen square. Yeah, I get to name something after myself besides the procedure. Shot. Right, you know what Camden's triangle is? The safe zone in the lumbar spine. We're going to have Deuk-Magen square. I like that. All right, do we have a question, Sean, from our audience? Sean?
Yes, we have a couple.
Okay, we'll take the questions.
One of our viewers asks, what is the 1, 3, and 5-year follow-up on a patient who undergoes DLDR?
What's the 1, 3, and 5-year follow-up on patients with DLDR? Very good question. So we have 6-month follow-up numbers and we have 6-year follow-up numbers. I don't have the 1 and the 3, but I have 6-month and 6-year. So, shot. All right, good. So I just got the soft tissue out of the end, and we're going to do a discogram. The answer is for 6-month follow-up for neck pain, axial pain, basically, either neck or back, it is 90% relief of the pain. And it's 92% relief of the radicular symptoms. At 6-year follow-up, it's 95% relief of the pre-surgical axial pain, which is neck or back pain. That's it right there?
Right.
And it's 95% relief of radicular symptoms. So what am I talking about? People that have this surgery for a herniated disc have the surgery for, 95% of headache as well. Cervicogenic headache coming from the neck. 95% relief. So what am I talking about? People that have herniated disc don't have surgery for the herniated disc. People that have a herniated disc and have symptoms from the herniated disc have surgery for the herniated disc. So just having a herniated disc by itself is not a reason to have surgery. I would personally never operate on a patient with a herniated disc that has no symptoms or signs. We'll talk about what signs mean. No good surgeon that I know would operate on any patient that has a herniated disc without having some symptoms or signs related to it. Okay? So what are symptoms? Symptoms are pain in the neck or back from the herniated disc, or nerve root irritation or compression. So what are those symptoms? Those are pain shooting down the arm or leg, numbness in the arm or leg, tingling in the arm or leg, or weakness in the arm or leg due to the nerve root being affected by the herniated disc. Notice how I said affected, not compressed. Because most radicular symptoms, which is your arm or leg pain, numbness, tingling, or weakness, is due to irritation of the nerve root rather than compression of the nerve root. And if all you're looking for is compression, you're going to miss 90% of the patient's problems. And so they're going to be told that there's nothing that can be done, and they're going to end up suffering the rest of their life for no reason because the surgeon failed to make the right diagnosis or provide the right treatment. So those are symptoms. Symptoms are things that patients come in complaining about. Shot, headache. Definitely don't want to advance that anymore. Shot, headache from the neck going up to the head, neck pain, pain in the neck that can radiate into the shoulders or just stay in the center of the neck. Arm weakness, numbness, or tingling. Shot. Shot. Almost there. Now, what are signs and how are they different? A sign is different than a symptom. A symptom is what the patient complains about. A sign is what doctors find when they examine a patient, okay? And there's a huge difference. Shot. A sign is something objective, okay? It's not something subjective. It's not something the patient complains about. Again, it's not something they necessarily verbalize. It's something the doctor finds on the physical exam, which is why the physical is so important in evaluating patients with neck and back injuries, okay? So signs, they include weakness on exam. And a lot of times the patients have no idea they have weakness because the weakness happens gradually. So it's egosyntonic, meaning that their awareness of it is minimal to none. So they're not aware they have it, right? And then there's signs of numbness. So if you're examining a patient and you're touching their skin and they're numb because they can't feel you touching, that's a sign of a problem with sensation. So a motor problem or weakness or a sensory problem or numbness or a spinal cord injury with brisk reflexes or spasticity, which is really tight muscles and restricted movement, balance difficulties that you see, or patient sways on exam. So there's a lot of things that we doctors look for as evidence of damage to the nerve or spinal cord on exam. We call those signs, okay? And then there's headaches when you have a cervical disc herniation. And we call those cervicogenic headache. They're a headache that comes from the spine, specifically the disc herniation, irritating the dura through inflammation. So when I'm answering the question about 6-month and 6-year follow-up, I am answering with respect to complications. I'm answering with respect to outcomes to eliminate patients' preoperative symptoms of neck pain or back pain, arm weakness, arm numbness, arm tingling, comparing before surgery to after surgery. So when I say there's 90 or 95% elimination of preoperative neck pain, headaches, arm symptoms, or back pain and leg symptoms, that's what I'm referring to. So that's what we look at. We look at what symptom the patient had, they came in with, that they had their herniated disc or Deuk laser disc surgery done for. So if a patient has a tumor on their ear and I'm doing a lumbar Deuk laser disc repair, the tumor on the ear will still be there. It's unrelated. And there's lots of things that people have that are unrelated. I had a patient come in and say he has leg pain, back pain, and numbness in his scrotum. So I looked at his MRI and I said, there's no way the herniated disc is causing the numbness in your scrotum, but it certainly is causing your back pain and your leg pain. So don't expect the numbness in your scrotum to go away with surgery. We need to be looking for a hernia or something else, some other cause. So patients come in with these complaints, please answer it, and they think sometimes that all of it's related to a herniated disc, but it's not. And that's one of our biggest challenges, is getting people to understand what is and what is not related to the herniated disc. Who is it? Let me see. Let me see the front. Who's the caller?
They have an alarm at 4641 South Tropical Trail, security.
Hello? You're calling? Yeah, please call my wife, son. No, definitely not. No, I can't give it to you. I have people standing around me, and I don't know who you are. But thank you. Try reaching son. I'm in the middle of surgery. All right, bye-bye. Don't you love it when the alarm company calls you because your alarm's going off in the middle of a broadcast of live surgery? But anyway, that is why it's live surgery. And again, I have no desire to hide anything that we do at any moment, at any time, in any way. You get to see it all. This is reality TV at its finest. You guys know that reality TV is actually highly edited, but Deuk Spine Institute's public broadcasts of our surgeries are not edited. Saves me on the editing fees. You like that? Yeah, I don't have enough money in the foundation to pay for editing. Because nobody out there donates to the foundation when they all should. They don't. That's okay, I didn't expect them to. All right, so this is the base of the herniation. See the pink stuff right here? That's actually part of the problem. That's called granulation tissue. So I think I answered the last public question pretty well. Hopefully I did. We don't have 1 year, 3 year, and 5 year follow-up. We have 6 month and 6 year follow-up. So just for those of you who are wondering, like, why don't we have it? There's no requirement to have that. That was just what that particular viewer was asking. So, but we do have short-term and long-term follow-up, and we know the results of the surgery. That's why we do these surgeries, because they're actually proven to work.
We have a few more questions.
Yes.
One of our viewers asks, in what case would a rhizotomy or nerve block be more beneficial than surgery?
In what case would a rhizotomy or a nerve block be more beneficial than surgery, was the question. So let's take those one at a time. What is a nerve block? A nerve block is like what the dentist does when you go get your teeth worked on. They take a needle, stick it in the back of your mouth, and they put some numbing medicine. It's called a nerve block, right onto your nerve that goes to your jaw, right, or goes to your upper teeth. And they basically block the nerve from sending pain signals up to your brain. So they're basically short-circuiting the pathway for a little while, okay? That's a nerve block. What's the problem, folks? It wears off. So what's the purpose of a nerve block? Nothing. We don't do nerve blocks at Deuk Spine. It's an old technique. It's useless, basically. And I would never recommend a nerve block. So in the last, 20 years, I've ordered 0 nerve blocks because they're absolutely useless. It's no different than a myelogram. Totally useless. Outdated technology, technique, has no long-term benefit for the patient. Now, is an epidural useful? Absolutely. We do epidurals all the time. There's a lot of bad stuff in the press about them, but that's really promoted by the insurance companies that don't want to pay for them. So epidurals done properly are very safe. Of course, there's risk. There's always risk with every type of surgical procedure, but surgery is necessary to fix problems, okay? There's nothing wrong with doing an epidural. This viewer did not ask me about an epidural, they asked me about a nerve block. But I'm just mentioning epidurals because we do believe in epidurals. An epidural is like a long-term nerve block, so to speak. There's a herniation right there. Now, they also asked me about, I think, a radiofrequency ablation, was it, or a medial branch block? Which one was it?
It was a radiofrequency ablation.
Yeah, radiofrequency ablation. So what is that? That's a procedure where the doctor is treating pain that comes from the spine. So there's really 3 relatively common causes of spine pain in the world. There's 2 of them that are pretty common, and one of them is not so common but still important. So the most common cause of spine pain in the world is called facet pain. Facet syndrome, F-A-C-E-T, F-A-C-E-T. Will you type that, Sean? And give them a link to our, those are all herniations, by the way, coming out. Give them a link to our, so much to talk about, folks. I need to talk faster. Download the Deuk Spine Institute app, okay? Go to your cell phone or your computer and go under the app section, and Deuk Spine Institute has an app. It's called the Deuk Spine Institute app, believe it or not. And it's free. We don't charge for it. We do this as a service to the public to help understand spine conditions. And in that section, there's a whole couple of sections under treatments that talks about rhizotomy or RFA, radiofrequency ablation, rhizotomy, same thing. And you can learn a lot about it, more than I can teach you right here. But I will say this, the number one cause of pain in the spine, chronic pain, is injured facet, F-A-C-E-T, joints. And the facet joints run from your tailbone all the way up to your skull. And about every finger breadth, every width of your finger, you have another facet joint. So there's a lot of them. They run from your tailbone, where your butt crack is, all the way up to your back of your head, okay? So facet joints get injured quite often, and they get inflammation inside that joint. And it's called a diarthrodial joint because it's a true joint. It has a cartilage surface and a joint capsule, synovial joint, and those get arthritis in them. And so the number one cause of neck pain or back pain is actually inflammation in the facet joints. How do you treat it? Well, you start out by doing just conservative treatment, some anti-inflammatory, some physical therapy, behavioral restriction, modification. Then if it continues, you do a procedure called the radiofrequency ablation. And that's the procedure done mostly by spine surgeons or interventional pain management doctors. And what it is where you go in and you take a needle and you basically kill the pain nerve to that joint by burning it at 80 degrees Celsius, okay? And Dr. Patel is one of the best in the world at doing that. He works with me here at Deuk Spine Institute. He probably is the best in the world, in my opinion, at doing it. He does it cervical, thoracic, and lumbar. As a matter of fact, this patient I'm operating on right now had it done prior to me coming in here and doing this Deuk laser disc repair surgery. He had it done on his thoracic, okay? So when people have facet pain, F-A-C-E-T pain, they get the rhizotomy done if the pain is chronic and doesn't go away with less invasive treatment. So do I believe in RFA, radiofrequency ablation for facet pain? Absolutely, 100%. By the way, that hole right there is the neuroforamen on the patient's left side at C3-4. And all those herniated discs were sitting in that foramen pinching on the nerve. I just got rid of them. I still think there's a few more that I need to get rid of, like this stuff right here. But I'm just going to keep working and talking. So we believe in radiofrequency ablation at Deuk Spine Institute. It's a very important treatment for facet pain. Radiofrequency ablation will not fix disc pain. So if you have pain coming from a disc herniation, the radiofrequency ablation will not fix it, period. If you have a pinched nerve from a disc herniation, the radiofrequency ablation will not fix it. So what I'm getting at is you have to be selective in when you do the radiofrequency ablation and make sure you don't do it when you don't need to do it. Does that make sense? You only do it for a facet syndrome. It's really easy to diagnose facet syndrome. You do what's called a medial branch block. Basically, we go in and numb up the facet joint with some Novocaine and just see whether or not that block is going to work. So people, I was asked earlier, do you believe in nerve blocks? The only nerve block I believe in is a medial branch block. But the nerve block that I was talking about that I don't believe in is a nerve root block, which is still a technique done by many doctors that I think is just useless. There's no place for it. This looks like a subligamentous disc herniation. In other words, this is a herniation at this level. Who is it? You don't have to answer it. He's not important. Why are you laughing? Because he's my brother? And I say he's not important? He thinks he's important, but he's not.
He's doing laser.
He's doing laser. He better not be doing laser. He doesn't know how to do laser.
What's his expertise?
Armin is a spine surgeon, like me, but he's only trained in traditional spine surgery. He doesn't know the endoscopic surgery techniques.
You haven't been able to
Teach him?
his arm?
I've talked to him many times about learning, but he's stubborn.
He is?
Oh,
That's
he's so
younger.
pig-headed. He's younger. He's 10 years younger than me.
Wow.
Yeah.
He went to St.
No, he didn't go to the same training program. He went to a lesser training program. He went to Tampa General. He went to USF. I say that tongue in cheek. I hope Dr. Van Loveren's not watching me or listening. But no, Tampa is a good hospital, but he learned the traditional surgeries, fusions, artificial discs, X-lift, O-lift. He didn't learn endoscopic because there's nobody there doing it. The fact of the matter is the reason why there's only me doing this is because the residency directors in spine don't know about this procedure, and the ones that know about it can't tell their residents that they don't know how to do something this significant, so they hide and say, oh no, it's just,
So does he send patients to you?
Does he send patients? No.
No.
No, he doesn't send me. He keeps them. That's why I told you, he's not important. Yeah. No, he's a good surgeon, don't get me wrong, if you want a fusion. But he still doesn't even do a fusion as good as I do. And I've tried to teach him, but he doesn't listen. He knows better than me. It's all that young generation, the new people. They always think they know better.
I had had it actually. I haven't been in academics for 30 years.
Yeah.
I just want to do cases for myself and control my own.
Right? That's how I am.
Yeah.
I don't like dealing with the politics. It's just
Yeah,
nonsense.
It's very difficult. And they're very sensitive.
Yeah.
Try to get
Oh, try to teach them. They know everything.
Yeah, just try to be involved in the patient care. They go very They're like, get out of here. I know how to do this.
Oh, really?
Oh, yeah.
And then the patients end up with pneumonia after surgery or some complication. Of course they do. They treat blood pressure changes with sedation
Yeah.
rather than, properly treating it with the blood pressure medicine. Yeah, yeah. That's why I don't work at the hospital very much, because it's dangerous for the patient.
They're taking over everything.
They're taking over. Of course they are, because the insurance companies want to pay cheap.
Now, I don't know if you know Sebastian. You know Sebastian?
Sebastian?
River Medical Center on Route 1.
Okay, what about it?
I went there for locums, but for the last few months, the hospital wants to take over the group. And behind their back, they came out and said, you're fired. Right?
Wow, yeah.
And then they have spoken to the CRNAs.
Oh yeah, they're going to keep
And
the
they, what
CRNAs.
they want them to do is take calls. And
Take
they
call.
take calls by themselves.
And who's going to supervise them?
Surgeon.
Surgeon.
Yeah.
Supervising the nurse anesthetist.
Correct. In a
That's
hospital
crazy. That's
setting. And they
crazy.
do a lot of sick patients.
You know who's driving this is Blue Cross Blue Shield. They're driving all of it. All of it. Because they're trying to lower their costs. They don't want to pay.
And then the CRNA said, first of all, they don't take calls where they are now. And they said, we want to get paid as much as the doctors.
As much as an anesthesiologist, right? Yeah, it's
And that's
disgusting.
where the negotiation is going on.
Yeah, yeah.
I'm not saying that the people who are there are really some of the best. But
So I'm having a conversation with my anesthesiologist, Dr. Calcarney. And for those of you who tuned in before, she and I worked with each other in Gainesville at Shands Hospital when I was training as a resident, and she was an attending anesthesiologist. And we
who was
kind of,
his boss?
Whose boss?
Your boss.
You are not my boss. Get out of here. You're fantasizing. No, she and I worked in the operating room. I was the chief of neurosurgery residency, and she was the anesthesiologist. We didn't argue. You and I didn't argue. You argued with the other attendings. Yeah. You and I may have had a spat one time, which is why what I remember. But nothing major.
The Australian guy, he didn't like.
Lewis, Stephen Lewis. Yeah, he didn't like many people.
Yeah. He didn't like to. He used to have that poker face.
Oh yeah. Yeah, but he was a good surgeon. He brought some interesting stuff to the residency. Some technique, how he turned the temporalis flap. Very interesting.
Friedman actually liked him.
Yeah, because he was a pioneer. Lewis is a pioneer.
He was.
And he's a good surgeon. And he fulfilled the vascular need when Art Day left. When Art Day took off, Art left us high and dry. So Steve Lewis took over all the vascular stuff, which is good. Oh, look at that herniation. No, he was never chief of the service. Lewis wasn't Art Day. Art Day was a special man. He did a lot of teaching of the residents.
Who's Archie again?
Arthur Day, like one of the top and neurovascular. We're done.
You're done.
Well, when did he wasn't there. Art left. So there was a huge battle in the department for chairman. When Al Roden retired, right, they found a new chairman to take his place. It was supposed to be Art Day. All the years they told Art Day, this medical school told Art Day he was going to take over as chairman. And then Bill Friedman came. Bill Friedman had more publications, brought in more money. I mean, Bill Friedman, as you know, does a lot of surgery. No, he does brain tumors. He does big surgeries. He doesn't do spine. He does all cranial. He doesn't do epilepsy. He doesn't do vascular. He just does tumors. He's a tumor guy. And he brought in a ton of money with radiosurgery. Right, he was one of the pioneers in radiosurgery. He was one of the early adopters of radiosurgery. Yeah, the linear accelerator, gamma knife. He was a LINAC guy, and he had many patents for things that he developed with Frank Boba. Yeah. Anyway, we're talking about Shands Hospital in Gainesville, one of the best neurosurgery training programs in the world at the time that I went there, which is why I went there.
So what do you think about Brian?
I don't know Brian well. He came on after I left.
He does a lot of interventional.
You're talking about the spine or the cranial?
The neurosurgeon.
But Brian Ho, right?
Brian Ho.
But which one is he? Is he the vascular or is he spine?
He does interventional. He is. I didn't work with
One of them is Daniel. I can't remember which one.
Is the spine.
Daniel's spine. So Brian, I didn't work with Brian. I don't know anything about Brian. I know he's the chairman, but I don't know anything about him.
He's a good guy and good surgeon.
So what happened was Art Day was there as one of Rhoton's very first residents, okay? And he stayed on as faculty all those years, developed a reputation of being one of the best in the world for aneurysms. Yeah, you can wake him up. We're done. And Art Day was supposed to be chairman. He had a lot of publications, a lot of connections. He was politically connected. He was involved in the ABNS, American Board of Neurological Surgeons. He was the chosen one to follow Rhoton when Rhoton retired. But then came Friedman, who outcompeted him and ended up winning the chairmanship. Well, when Friedman got chairman, Art Day left, Rick Fessler left because they all wanted to be chairman. So we lost some of our best faculty. That's right when I graduated.
Could they have worked with him?
No, they didn't. They hated Friedman.
He's not easy to get along.
He's not easy to get along with, but also they thought they should be the chairman because they were there longer than him.
And they had been there for.
Yeah, but the medical school selected Friedman because of his publications and everything he did, the money he brought in. They couldn't lose him. Anyway, it became a big political catastrophe.
That's what happens is
Let's keep the
number of
blood
years-
pressure low. Not too low, but 110s.
I'm thinking if I can.
Give what? Labetalol?
Yeah.
Whatever you need to do to treat the blood pressure.
That I grabbed it last time. I can do that.
Whatever you want to do. Hydralazine is a balance dilator.
Correct, which is good, controls blood pressure, right?
That's up to you. You're going to reduce the afterload and the preload.
Good for the heart, good for
Yeah, I know a little bit about cardiac physiology.
Does it have any receptor blockade?
Does it have a receptor blockade? No. It acts on the smooth smooth muscle. All right, let me get back to my audience for a second here. All right, folks. I don't know if you can see this, but the surgery was done through this tiny incision right here. Can you all see that?
Yes, we can.
And you see my finger. So you can see how tiny that incision, 4 millimeters. I fixed both disc herniations. And this patient otherwise would have had an ACDF, a fusion. They would have an incision this long, all the scar tissue, metal in their neck, but they have it au naturel with no metal, no fusion, and they get to keep the disc moving. Keep some pressure and then put the bandage on. Thank you, everybody. Great job. I'm going to head over to the conference room and answer some more questions. So if you have questions for me, I'm Dr. Ara Deuk-Majan. You just watched the 2-level, 2-disc, anterior cervical Deuk laser disc repair. Endoscopic repair of the disc. Most of the surgery was done doing what's called an annular debridement, and it is the only surgery in the world that does an annular debridement, and that's why we're able to cure the disc pain, the neck pain, and most of the arm symptoms, and headaches. Those are still good. I've got to say, today is a good day because I have fresh coffee waiting for me, my Folgers, and I'm here with Sean, who has taken over for Zach. Zach has, as some of you know who follow us regularly, Zach has left. He went to Utah where his family is. He left boring old Florida and went back to Utah. Zach's a young man, and I guess he missed his family, which is fine. But Zach is still working for us, and Zach is helping us from Utah, but he's doing it remotely. So he's still part of Deuk Spine Institute, and we greatly appreciate that. Zach has made massive contributions to our online presence in terms of helping us broadcast these surgeries live and going to platforms, social media platforms that people actually use and are interested in learning more from. So Zach initiated that project for us. And then he also built the Deuk Spine Institute app. So I'll just do a quick plug for the app in case you didn't hear it earlier. There is an app for your phones or your computers. You can download the app for free, and it's on the iOS Apple platform as well as the Android platform. You know, we used to call it the PC platform, but it's the Android platform. So no matter what phone you have, there's an app for you, and they're probably the best app, I think, out there for spine, for any kind of spine issues, herniated disc, stenosis, radiculopathy, myelopathy, anything related to the spine. We don't have much on the app with respect to tumors of the spine, because tumors are not that common. In our practice, we deal with primarily what are called degenerative conditions, such as disc herniations, disc bulges, disc collapse, spondylosis, spondylolisthesis, deformities, degenerative deformity like scoliosis or kyphosis, facet abnormalities, chronic pain. That's really what Deuk Spine Institute deals with, and that's probably 95% of spine care in the world is degenerative conditions. About 5% is going to be trauma, like fractures, or, and I don't mean trauma because all disc herniations are traumatic, but I mean trauma like high-speed motor vehicle accidents where there's fracture dislocations and fractured vertebrae, et cetera, or tumors and infections of the spine, again, rare. So the vast majority of spine care in the world, about 95% of people with spine problems have what's called degenerative conditions, and that's what Deuk Spine Institute treats. That's what our app is focused on, is degenerative conditions of the spine. Anyway, the app download costs $10,000. Oh, but I heard we're running a special. It's free. It's free this week only, and then we're going to be charging $10,000 a download. Just kidding. I do have a sense of humor. It's unusual to find that in neurosurgeons, but I do have a sense of humor. And the app will be free for as long as I can tell. Now, some of the neat things on the app, number one, you have access to our database of common spine degenerative conditions like hernia disc, facet syndrome, and Zach has done a great job of building those up, not just with content, but not just written content, but some pictures, videos. There's also the ability to request a free MRI review. So if you or someone you care about has a spine problem and they have an MRI or a CAT scan, you can submit that study through the app and the report, and you can get a free MRI review. I actually do the MRI reviews for Deuk Spine Institute. So if you submit your MRI to Deuk Spine Institute in the year of 2019, 2020, and for the foreseeable future, Dr. Ara Dukmajian, the CEO and founder, is the one who actually personally reviews your MRIs to see if you're a candidate for treatment at Deuk Spine. So my team helps me. They'll reach out and contact you and get some questions answered, like where's your back pain, how long have you had it, where's your neck pain, does it go into your arms, do you have weakness, et cetera, et cetera. We ask some basic questions, and then I look at the MRI, make recommendations. You can also request a video conference. We're the only spine center probably in the world that does free video chat. You get a 5 to 10 minute session with me personally where I can answer questions for you about your neck or back problem. And if you have an MRI done and you submit it, it makes it even better for me because then I have an MRI to look at and review with you. Typically, when I do a video conference or video chat, it's usually on Thursday or Friday of the week, and I get on there with the patient or potential patient, and you guys can look at me and talk to me, and I can pull the MRI up, and I can show you on the MRI where your problem is and what I think needs to be done to fix it. Now, for those of you who watched this surgery, you watched a minimally invasive spine surgery. This is the most advanced spine surgery in the world to treat herniated discs, spinal stenosis, pinched nerves, okay? And the surgery that you saw is not available in almost anywhere else in the world but at Deuk Spine Institute. Does that mean there's no endoscopic spine surgery being done anywhere else in the world? No, it doesn't. It means that the particular technique that I use to repair the disc herniation, most specifically annular debridement, is unique to the Deuk laser disc repair. The Deuk laser disc repair is the name of the surgery. It's the type of surgery we're doing. So it'd be like saying I'm having an artificial disc done, or I'm having a fusion done. I'm having a Deuk laser disc repair done. I'm having a laminectomy done. So it really is a specific type of procedure. Now, when you do laminectomies, every single spine surgeon in the world does their laminectomy differently. So if I took a patient and I gave them 10 different spine surgeons, their laminectomy would be done 10 different ways, guaranteed. The spine surgeons never do exactly the same thing, because literally through the surgery, you are making, as a surgeon, about 1,000 decisions per surgery. So every one of those 1,000 decisions has to be, you know, green or red or blue, left or right, up or down. And every surgeon does things differently, whether it's the tools that they use to do the surgery, whether it's the positioning of the patient, whether it's the medications they give during the surgery, how they control the blood pressure, how much muscle dissection do they do, whether they take the ligament out of the foramen, whether they take the facet out of the foramen, there's literally 1,000 variables. So just as there is 1,000 variables with the most simple spine surgery, there's also 1,000 variables with Deuk laser disc repair. So if somebody else tries to do laser spine surgery on you, you're going to get a very different experience, outcome, and result than if you had it done, say, at Deuk Spine Institute. So I can tell you right now, the number of surgeons in the world that can do anterior cervical transdiscal endoscopic surgery, there's probably less than 10 in the whole world that are capable of doing it. How many are actively doing it? I don't know, but I would say less than 10. In the United States, I'm the only one doing anterior cervical transdiscal endoscopic surgery. There is one other doctor, Dr. Joe in Pittsburgh, who was doing anterior cervical surgery endoscopically before me, but his technique is very different. And in my opinion, I would never do his technique because it's a lot riskier, poor visibility, and much worse results. My results are good enough to publish. They've been peer-reviewed and published. So there's no experimental side of my surgery. The outcomes are known. They've been peer-reviewed and published. The way that doctors make a treatment not experimental is by having that treatment studied with a study where you look at the outcomes of the patients who have the treatment and those that don't, and you kind of compare them, and you submit your manuscript where you type everything up, all the results up, to a journal that is published in the National Library of Medicine, and the editor and his or her team of what are called reviewers review the manuscript, and those reviewers are always experts in the field that the manuscript is being published in. So for spine surgery, it would be neurosurgeons and orthopedic spine surgeons. And the Deuk laser disc repair has been peer-reviewed and published multiple times. So the outcomes are known. It is not experimental surgery. Everything we do is with FDA-approved equipment and medications. But that being said, this is a very state-of-the-art surgery so that there's not a lot of surgeons that know how to do it. You, the public, are learning at a faster rate than the surgeons are, because surgeons really only learn what they learn in their residency, and there's no residencies teaching this, okay? So I've tried to work with residencies, but the residency directors really don't want to admit that they don't know such a huge, massive chunk of spine surgery to their residents. Otherwise, they lose credibility, they lose face. So, plus, there's another reason. which is probably a bigger impact on the reason why this endoscopic surgery is not being taught in residencies. That's because if you notice during the surgery, how many screws did I put in? None. How many metal plates did I put in? None. How much hardware cages did I put in? None. How much biological material, bone graft, did I put in? None. There's a multi-billion-dollar industry built around spine surgery, and it has everything to do with putting screws and rods and plates and metal and plastic and artificial discs and biological material into patients. Those implants, we call them, or biologics, are very expensive, and there are companies that manufacture them and make billions of dollars in profits a year. Those companies don't want the Deuk laser disc repair out there. They're not supporting my procedure. And they have legions and legions of spine surgeons that sit in high-ranking places, primarily in residency positions as residency directors or spine directors. And basically these doctors, for the most part, these spine surgeons, they actually get money from the implant companies for putting in spinal implants. Now, this is now considered illegal, but it doesn't keep a lot of them from doing it. They have ways they work around. They have speaking engagement contracts where they get paid thousands of dollars to go give talks. They have ownership of stock in the companies. They have they develop new technology, they patent it, then they sell the patent to the company for millions of dollars. I've heard stories of spine surgeons in control of residencies that make 20, 30, 40 million dollars from these implants. My point is, there's probably 90% of the spine surgeons that I know that are on the take from the implant industry. Well, the implant industry doesn't want the Deuk laser disc repair to be popular. They don't want anyone getting it because there's no implants. They're not making money off of it. So I'm considered their competition. So I, Dr. Ara Deuk-Majan, with my little old center here in Florida, am competition to the biggest industries in the United States. The Medtronic, Sophomore Danix, the DePuys, Johnson & Johnson. I mean, these companies make billions of dollars a year on spinal implants, and they don't want my surgery popular. They don't want it taught to residents. They don't want it taught to fellows. They don't want it approved. They don't want they want it to disappear, basically. Yeah. So what's good for you, the patients, is not good for their bottom line. That's what it comes down to. And so they're doing everything within their power to keep my surgery from being known. Well, guess what? This broadcast is the anti-venom to their poison. And that's why it's so important that we keep broadcasting, to make the world aware that there's a way to fix spine problems without doing extensive invasive spine surgery. So what about me? Do I ever do fusions? Absolutely, I've done fusions. I've done thousands of fusions on spines in my career. I've been in the business for 22 years as a neurosurgeon, and I was taught by some of the best spine surgeons in the world, but those spine surgeons were fusion surgeons. So I learned all the fusion techniques and artificial disc techniques, okay? So I actually have the perspective of an expert in fusion, an expert in artificial discs, and an expert in minimally invasive surgery, endoscopic surgery, and also an expert in therapy and an expert in interventional pain management. So all the modalities related to spine care, I have expertise in. So that gives me the ability really to look at all spine problems and figure out what's absolutely best for each patient based on really what's best for the patient, and not just look at everything from the perspective of surgery as a surgeon would normally. All right, without further ado, I'm going to get to the questions. So, Sean, you want to give us our first question from our audience?
Our first question is, what is the probability of complication with this procedure, meaning the DLDR procedure?
Great. So the first question, and really I just took a break so I could drink some coffee before it got cold. First question is, Dr. Deuk-Majan, what is the probability of complication with this procedure? Okay? I'm going to answer this question carefully because I don't want to mislead the audience in any way. Probability means the likeliness that something will happen. So this is a really complex answer. So if Dr. Ara Deuk-Majan, the founder, the guy talking on the mic right now to you, does this procedure, the probability of a complication is less than 1 in 1,000. How could I say that? Well, it's factual. I've done 1,000 cases. I've had 0 complications. So less than 1 in 1,000 if I do the surgery. If this surgery were done by somebody who has never done it before, like other doctors in the area that proclaim to do laser surgery, the chance of a complication would be virtually 100%. So the probability of a complication would be virtually 100%. So the risk of complication is proportional to the experience of the surgeon, the capability of the surgeon, the equipment they have available to make sure it's the right equipment, the right flow, the right anesthesia, the patient's blood pressure, relaxation of the patient with muscle relaxers, blah, blah, blah. Literally 1,000 different variables. But if those variables are stacked in the favor of the patient, by me doing the surgery at Deuk Spine Institute in the Surgery Center Viera, the probability of a complication is less than 1 in 1,000. If it's done elsewhere by other surgeons, the probability of complication goes up, for sure, dramatically. Now, the next thing I think you're asking, which the audience should understand, is what is the risk that could happen? What kind of complication can happen? These patients can die during surgery easily. I am doing the surgery right next to the carotid artery. The carotid artery feeds the brain blood. 40% of the brain's blood comes from the right carotid artery, normally, and 40% comes from the left carotid artery. That's 80%. The vertebral arteries provide the other 20% as 10 and 10. So if I injure the carotid artery during the surgery, I'll kill the patient. There's no doubt about it. If I injure the jugular vein, there could be a complication there as well. It could be less severe. If I injure the esophagus or trachea, if I injure the spinal cord, they're going to be paralyzed. So if I injure a nerve root, they're going to end up having permanent weakness. So there's a lot of potential for injury, okay? There's a lot of potential for complications. In this particular anterior cervical Deuk laser disc repair, the patient's intubated. So the risk of losing their airway during surgery and the patient suffocating and dying from an anoxic brain injury is very low, as long as the machines are working and the sensors are working and the anesthesiologist is paying attention. Again, these are good questions, but the answers are complex and sophisticated, and they're not simple. But the truth is, if you boil it down and distill it, the chance of complication with me doing this surgery on a patient is going to be less than 1 in 1,000 that they're going to have a complication, because those are real numbers. Those are facts. Those are based on 13 years of doing this procedure. Yeah, I hope I made my point clear. Next question.
Our next question is, if you're treating the lumbar spine bilaterally, does it require 2 separate incisions, or can it be done through the same one?
All right, great question. So somebody is saying, Dr. Deuk, when you do the lumbar, the lower back, not the neck like we just watched, but the lower back, and they have, say, herniations on both sides, left and right, at one of the discs, and their symptoms are on both sides, down the legs. Down the legs is key. Do you have to go both sides? Yes. Do you have to make 2 separate incisions, or can you treat both sides with 1 incision? The answer is no. You cannot treat both sides with 1 incision. You must make 2 separate incisions. And so here's what I use to figure that out, okay? If the patient comes in and they have back pain coming from a herniated disc, but they have leg symptoms only on one side, then I'm going to just go on the one side that they have leg symptoms. So if their right leg has pain in the right leg, I go on the right side. If they have pain on both legs and they have a herniation that's on both sides, then I must make 2 separate incisions on both sides. There's no other way to do it. If the patient has predominantly right leg pain, down the right leg, and they have a little bit of pain on the left side, then I would just go on the right side, because chances are that I'm going to be able to remove enough of the disc herniation that it's going to decompress the other side and allow that side to heal. I've seen it happen many, many, many times that way, where patients with right leg pain but a little bit occasional left side pain down their left leg, I do the right side and their left leg pain goes away. So in those cases, I only make 1 incision on the right side. That's what I always hope for my patients, that I only have to do one incision. But some people have herniated discs on both sides, and they're big, and they're pinching the nerves on both sides. In those cases, you must make incisions on both sides. All right, I'm going to give you back to Sean for the next question so I can get a sip of coffee.
Our next question comes from another physician. He says, if I'm a doctor living in South Africa interested in learning this endoscopic surgery technique, where do I start?
Okay, so we have a doctor in South Africa. Nice to meet you, first of all, from one professional to another. I assume that you're a spine surgeon. So to answer your question, if you're just a doctor, like a primary care doctor, forget about it. If you're a spine surgeon, which I assume you are, either a neurosurgeon or an orthopedic spine surgeon, then you would learn from me. And the way you start is by, unfortunately, there's no easy way to do this. You have to travel to Florida and plan on living here for about a year to learn from me directly, helping me with my patients and my surgeries. That's the only way you're going to learn. There's nowhere in South Africa that this surgery is being done. There's nowhere in other countries the surgery is being done except for South Korea. And the Koreans, I would not use their technique. I've watched their technique. I've learned from the Koreans. And the surgeries that I've seen them do, unfortunately, are very risky for the patient because they keep their patients awake during surgery on the neck. And the patients are moving around during surgery. And there's been several patients paralyzed in Korea as a result of the patients moving around and poor surgical technique. Truly, it's very easy to paralyze a patient with a surgery if you don't know where you are. If you lose your anatomical, anatomical basis for your location, you're going to end up injuring the patient and their spinal cord. I don't know if you could appreciate it, but during the surgery, you could really see the contour of the spinal cord. We're millimeters away. And had I gotten disoriented, you're dealing with a piece of metal that is literally 2 millimeters from the spinal cord, and any wrong move could result in complete paralysis. Now, we were operating at C3-4 in this patient, and C3-4 is basically where your breathing center kind of ends in that area. So an injury to C3 could result in ventilatory dependent quadriplegic. And so what I'm getting at is there are surgeons who have done this surgery, not my surgery, but endoscopic anterior cervical transdiscal surgery with these tubes that have paralyzed and killed patients. I am not one of them, but that's because I won't let that happen because I basically figured out what's wrong with their technique, and I made alterations so that my technique doesn't expose the patient to the risk that they expose their patients to. In other words, I did what's called a root cause analysis as to why they had their complication, and I developed strategies during my surgery that are different than theirs that don't allow patients to have those complications. You know, there's principles that I live by. I tell my kids rules. Create rules for yourself to live by, and then you can avoid problems and complications in life. But you have to create those rules ahead of time, and you have to strictly follow them. Surgeons are no different. We have to strictly follow a set of rules and techniques and methods during surgery so that we have predictable outcomes and we don't get in trouble and harm the patient. So to answer your question, you need to come here to Deuk Spine Institute to learn the technique. So how do you get started? I would reach out by calling Deuk Spine Institute, introducing yourself, and asking to speak with Dr. Deuk Majan. That's me. We can do a video conference. I can meet you over the phone like I do with patients and get to know who you are, understand a little bit more about you. I'm not going to train you if you're still in the middle of training. You have to have some experience as a spine surgeon. I won't train an interventional pain management doctor, though they'd like to be trained. I'll train a spine surgeon, preferably a neurosurgeon, but I would accept an orthopedic spine surgeon in training as well. All right, and so that's an open invitation for anyone, any physician out there that's a spine surgeon that wants to learn how to do the surgery. I'm open to training anyone, as long as I feel that they have the potential to do the surgery properly. I will not train someone who I think will kill patients, hurt patients, or not follow my very, very specific algorithm and surgical technique. In other words, if you're a buffoon, I'm not going to train you. If you're highly intelligent and responsible and committed to performing the art of spine surgery perfectly to the best of your ability, and you have the ability, then I will train you. But you have to have the intelligence, you have to have the motor skills, you have to have the desire, and you have to have the aptitude to be able to be trained. I won't waste my time training someone who, in my opinion, will not be a great spine surgeon for their patients. All right, we'll take the next question. Oh, how do you reach us? Basically, the best way to reach us is to call, I don't know, great question. How do they reach us? I guess they can contact patient services. Just go to the Deuk Spine Institute app on your phone. Again, download it, and there's a contact us form. Introduce yourself and say that you want to meet with Dr. R. Deuk-Majan, and my team will get in touch with me, and we'll set up a video conference.
Put a link for it in the chat. And our last question is, if I have a herniation on my right side lumbar spine, why would it cause bilateral leg symptoms?
Okay, great. So I like this question because it's a great lead-in to talk about a few things. So one of our viewers says, hey, I've got a herniation on the right side in my lumbar spine. How would it cause bilateral symptoms in my legs? So let's step back, forest from the trees, and I'll answer your question. If you're asking me very specifically, Dr. Deuk, how could a right-sided herniation cause bilateral leg symptoms? The answer very simply is it cannot. It cannot. Period. If you're asking me, I was diagnosed with a right-sided herniation, how could it cause bilateral leg symptoms? The most likely reason is that they missed the diagnosis of the left-sided herniation. It's there. They just didn't call it on the report. I see this all the time. It's the most common problem with MRIs that are done today. As a matter of fact, we really strongly recommend and even insist that our patients that are having treatment at Deuk Spine get their MRI scan done here at Deuk Spine Institute for two reasons. Number one, our MRI scanner is of the highest quality, so we can see the details of the disc and not miss things. And number two, the radiologist that reads our studies is an expert in reading spines, so they don't miss things. What I find is that about 90% of MRIs done out there in the world are misread by the radiologists. So the quality of the study is pretty good. They can see the disc herniations, but they just don't call them. So in the report, they leave it out, okay? They leave the fact that you have a herniation on the left side out. Now, many of them leave it out because they don't see it to begin with. They can't identify it or recognize it as a herniation. You'd think it'd be easy to do, but it's not. You see, radiologists are peculiar people. They're actually not really clinicians for the most part. Most of them just sit behind a computer and a desk and they look at studies all day long and they give their opinion about what they're seeing. Remember, they're looking at a structural study. They're looking at a picture. So they're supposed to report structural findings, right? But they actually inject subjective experiences and feelings into their reports, right? So if I asked you if this particular woman is beautiful, you may look at her and say, she's okay. I may look at her and say, she's beautiful. So it's a difference of opinion, but it's subjective, okay? It's subjective. So the radiologist will look at an MRI and say, there's no herniation. The next one will come along and say, there is a herniation, because there is a herniation. The one that says there isn't just left it out, basically. So why would they do that? It's simple. Their idea of a herniation is a herniation that they think is important. And most radiologists make the mistake of thinking that small herniations are not important, so they leave them out of the report. That is the wrong thing to do. If there is an abnormality of the disc, no matter how small it is, you should mention it in your report. Let the clinicians, the surgeons like me, figure out if it's important or not. So I would say 90% of the patients that come in and say, my doctor doesn't know what's wrong, they can't figure it out, well, they have a problem there that was just missed. Many times they have 2 or 3 disc herniations that were missed. So remember that 15-year-old girl I told you about? Well, she's the daughter of my best friend. My best friend is a lawyer, a corporate attorney in Los Angeles, and he took his daughter to literally the best spine surgeons and doctors in all of Los Angeles. And every one of them missed her disc herniation. It was obvious to me, but that's because I know what to look for. She had a herniated disc on the left side at L4-5. Her leg symptoms and her back symptoms were on the left side. I could see she had an annular tear, and there was a bulging disc. It was small, albeit it was small. I give them that. But I also have the advantage of knowing, because I treat patients every day with herniations that have pain. I treat them every day. I know that a disc herniation can be very, very small and yet cause massive pain. The reason is they're causing the pain via inflammation. Small disc herniations cause massive inflammation. Just think about that pimple on your face. Remember the pimples you used to have when you were younger, when they got really inflamed? They were swollen and tender. You push on that pimple and your whole side of your face felt like it hurt, right? Well, the disc herniation is bigger than those pimples, and there's inflammation in there. So anytime you stand up and move, you're putting pressure. It's like squeezing that pimple that hurts so bad. You can imagine the amount of pain people have. So it has nothing to do with the size of the herniation. It has to do with the fact there's inflammation going on, and everybody's experience is different. What matters, though, is that the patient has pain. And if you find the abnormality that's structural, no matter how small it is, as long as it can account for the patient's symptoms, then you have to treat it. So this poor girl spent a year and a half of her life with pain every day, every single day at 15 years old, which no 15-year-old should ever have to suffer with chronic pain, okay? And she went to all these doctors that were supposedly the best, and every one of them missed it. Every one of them blew her off and said, just do some physiotherapy, do some stretching. But I found it, and I fixed it. And this is a typical story. And now her pain's gone, 100% gone. And she's living a normal life in school, back in high school. I haven't released her to play basketball yet, and she keeps bothering me because she wants to play basketball, right? But I don't want her to re-injure that disc because I don't want to put her through another surgery. So we're going to take our time and get it to heal right, and then she can play basketball. But it takes a year to fully heal a disc, a year after surgery. So what I'm trying to say to you folks is very simple. The size of the disc, being big versus small, doesn't matter. What matters is the patient and the experience they're having. You have to pay attention to what the patient is telling you. This 15-year-old girl wasn't lying about her pain. This 15-year-old girl didn't have secondary gain issues. She wasn't trying to get narcotics. She wasn't trying to be, a drug queen. She wasn't trying to sell narcotics on the street. She didn't have any other reason to have pain other than she had pain. And so most of the patients I treat, almost every one of them, they're legitimate. They have a problem. They want to get it fixed. And as doctors, we owe them at least the dignity, and we owe them the respect to investigate their pain properly and make absolutely sure that you're not missing something that can be fixed and help these people. A 15-year-old girl has many years ahead of her. Many, many years ahead of her. Let's say 60, 70 years ahead of her. And if you don't fix that disc herniation, you're condemning her to 60 years of torture. Torture. And it's not just personal torture. These people with chronic back and neck pain, they don't just suffer by themselves in a vacuum. They have loved ones. They have relationships. And those relationships suffer with them. The people that care about them suffer with them every day. I can't even imagine the hell that I would live in the anguish that I would live in if I was a father of a daughter, if my 13-year-old daughter had back pain every day and I could do nothing to fix it. I would feel like nothing as a human being. I mean, I would feel hopeless and helpless, and that's what doctors do. They tell these people there's nothing that can be done. It's in your head. And as a parent or as a spouse or as even a child, you feel for that person every day. You suffer with them. You suffer with them. So that's why I do what I do. That's why I fix people, because their lives need to be fixed, because other people's lives need to be fixed, and because no one else can do it. You know, no one else can do this. Unfortunately, we have a country full of doctors that are incompetent when it comes to curing back and neck pain. They're brought up in a system that basically ignores pain and suffering and minimizes it, and just there's no desire on the part of doctors to do better for the most part. You know, I can't speak for every doctor, but 98% of them just don't care enough to figure out what's wrong and fix it. I'm in a very unique position in that I'm a spine surgeon. I can actually fix some things that need surgery to fix. And the ones that don't need surgery to fix, I still care. Just as much as I care about my surgical patients, I care about my non-surgical patients. So for me, if a patient has a back problem that doesn't require surgery, I still make sure that patient gets to the right doctor, usually Dr. Patel, and the right therapist, usually Dr. Schrumpf, to do their therapy. Because the therapy and the interventional procedure will fix them, as long as they get the right interventional procedure and the right therapy. So I don't just say, sorry, nothing surgical, goodbye, like all my colleagues do. Not my problem, I don't care, go suffer in someone else's office. That's not my attitude. That's not my belief. I think that's wrong. That's basically abandoning your patient. So I believe a doctor has a responsibility to make sure that their patient gets the care that they need in order to get cured, or if cure is possible, which it usually is with chronic back and neck pain. You just have to know how to cure it. All right, is that our last question? Apparently that's our last question. So again, I'm Dr. R. Deuk Majan, CEO and founder of Deuk Spine Institute here in Florida. And we appreciate you watching. We broadcast all of our surgeries live. I will say one more thing. We do have a Facebook group if you want to join. It's called Spine Surgery Support Group. Spine Surgery Support Group. And it's free and open to the public. We don't want people coming in and advertising. I had a couple of people who come in and advertise, and we don't allow their advertisements. But for the most part, it's really there, and I check it routinely. And if you have a question or you want to post something that's appropriate, then we'll allow it to be posted for the benefit of everyone that's a member of the group. But I encourage you to join Spine Surgery Support Group, Spine Surgery Support Group on Facebook. I check those questions, and I personally review everyone, and I respond to them as R. Deuk Majan. So you get my expert opinion. I'm a terrible typer. I don't have a lot of time to text, but I try to get an answer in there. So anyway, it was nice. I enjoyed our session. Have a